a
Okay.
59-year-old mother of two who is a
Right.
housewife from Colombo, 15,
Okay.
presented with gradually worsening of shortness of breath for 1 week duration.
Mm-hmm.
She is a diagnosed patient with several comorbidities such as diabetes mellitus, hypertension, dyslipidemia for more than 10 years duration, several
Okay.
ischemic heart disease events for
Mm-hmm.
8 years duration, and
Okay.
bronchial asthma for several years where she can't recall the onset.
Okay.
This time she presented with gradual worsening of shortness of breath for
Mm-hmm.
1 week duration.
Okay.
She has experiencing shortness of breath even after a simple activity for the
Mm-hmm.
last few years, followed
Okay.
by the ischemic heart disease event which has occurred in 2017.
Mm-hmm.
About 1 week back, she has experienced worsening of shortness of breath, where she has felt shortness of breath while she was resting as well.
Okay.
She explains associated paroxysmal nocturnal dyspnea, orthopnea, which doesn't
Mm-hmm.
associate with lower limb edema.
Okay.
Uh, the shortness of breath has been prominently experienced in the mornings. However, it has persisted throughout the day.
Mm-hmm.
She has been on drugs for her shortness of breath
Mm-hmm.
and cardiac conditions.
Mm-hmm.
However, the compliance has been poor over the past period due to financial
Okay.
issues. She doesn't reveal a history suggestive of uh, rheumatic fever in the past and has not uh, experienced a feeling of her own heartbeat over the past period.
Mm-hmm.
And there are no periods of brief loss of consciousness that
Mm-hmm.
has rapidly recovered.
Okay.
Usually, she gets exacerbations of
Mm-hmm.
asthma when she exposes to cigarette smoking or vehicle
Okay.
smokes. But this time, there
Mm-hmm.
hasn't been such exposure prior to the
Right.
worsening of
Okay.
shortness of breath. Patient denies hearing of any wheezing sounds, associated rhinorrhea,
Mm-hmm.
itchy skin rashes,
Mm-hmm.
which are associated with shortness of breath.
Okay.
Even though her husband is smoking, she does not expose to cigarette smoking, and there hasn't been a history of cough with sputum production to suggest
Okay.
COPD. She has been on treatments for a joint pain with swelling, which exacerbated with standing for a long duration since 2011.
Mm-hmm.
Possibly, it could be a
Okay.
osteoarthritis, and she denies a history of early morning stiffness of joints or deformities of joints due to the
Mm-hmm.
condition, and associated skin rashes, alopecia, or oral
Okay.
ulcers that suggest a connective tissue disorder.
Okay.
She denies a possible contact with a person with COVID-19 as well.
Okay.
She doesn't complain episodic shortness of breath, which associated with body itching, nausea, vomiting, or alteration of
Mm-hmm.
consciousness, and metallic taste in mouth to suggest
Okay.
an ongoing
Okay.
uremia. When her,
Darling. Okay. Continue. That's fine. Come.
when
You can
her
sit.
past medical
Okay. That's fine. Okay.
with regard to her past medical conditions, she has been diagnosed with diabetes mellitus more
Mm-hmm.
than 10 years ago, where she can't
Okay.
exactly remember the onset, and the sugar values at the
Right.
diagnosis was not remembered. It has been an incidental finding where when she has been admitted to another condition to
Okay.
the hospital. She has been started on oral hyperglycemic drugs at the beginning, um, and since the onset of the condition, her compliance for drugs has been poor due to financial and social
Okay.
issues. Throughout the course of illness, the drug doses has been increased, and about 4 to 5 years back, she has been asked to start on insulin. However,
Okay.
she has not used insulin. She has used insulin only for some months.
Okay.
She has a refrigerator at home to store insulin, but she says that she can't inject insulin by herself, and the family members are not supporting her.
Mm-hmm.
She has been given dietary advices several times. However, she is not working according to them. And she is taking high carbohydrate diet when the 24-hour dietary recall is considered.
Okay.
Uh, Due to her shortness of breath during small
Mm-hmm.
exertions, her mobility is restricted,
Okay.
and she is not engaged in any household activities for the past few years.
Okay.
With regard to the microvascular complications, she does not seem to have any autonomic neuropathic features
Mm-hmm.
and blurring of vision, passing of froth in urine, according to the history.
Okay.
She has undergone retinopathy and nephropathy screening about 3 years back, and they have been normal according to her. However, the records were not available with her.
Okay.
She complains pain in her bilateral lower limbs, especially during night time, and she gets the feeling of walking on cotton wool as well.
Mm-hmm.
However, she has not experienced any foot ulcers over the past
Okay.
period. She has experienced a past history of vomiting, abdominal pain associated with hyperglycemia, possibly a hypoglycemic event in the past history.
Mm-hmm.
She is diagnosed with hypertension more than 10 years back, and the compliance with the antihypertensive is also poor,
Okay.
and she has not experienced uh, uh, hypertensive emergencies as well.
Okay.
Also, she's having dyslipidemia for more than 10 years with poor compliance for drugs. She has experienced a
Tanaja,
ischemic heart
give me a
disease.
minute. Give me a minute. Show Ami Baba. Baba. Yeah. Okay. Continue.
She has experienced four cardiac events in 2012, 2016, 17, and the recent one has been in 2020. She
Okay.
has been advised to undergo a uh, bypass surgery. However, she has defaulted from clinic follow-up.
Mm-hmm. Okay.
Um, with regard to her bronchial asthma, she can't remember the onset, and currently she is on salbutamol dry powder inhaler to use in exacerbations.
Okay.
She experienced bilateral knee pain and swelling while standing for some duration, uh, and it is not associated with morning stiffness. So it is more suggestive of osteoarthritis, according to the
Okay.
history.
That's fine. Yeah.
She has been admitted to hospital due to bilateral lower limb cellulitis in 2016 and has been treated with IV drugs in that episode. Also, she has got tuberculosis in 2017, has
Mm-hmm.
completed 6 months of drug treatments, and while she was given the anti-TB drugs, she has developed body itching, and it has been diagnosed as hepatitis, and drugs have been changed
Okay.
after that.
Mm-hmm. Okay.
And also, she's having numbness over her fingers, which has been diagnosed as carpal tunnel syndrome in 2017, and
Fine.
she has not undergone any surgeries for that.
Okay.
Her past surgical history is not significant, and
Okay.
she's allergic to pineapple and
Mm-hmm.
possibly a one drug of anti-TB drug regime.
Okay. That's fine.
And with regard to the drug history, she has a very
Mm-hmm.
poor compliance for all the drugs and
Mm-hmm.
taking drugs from the pharmacy using previous prescriptions.
Mm.
And
Okay.
she has undergone Ayurvedic treatments 2 years back for the shortness of breath.
Okay. Mm-hmm.
Um, She's a second one of a family with 5 siblings, and
Mm-hmm.
one of the sibling has passed away due to a stroke.
Mm-hmm.
Both her parents have passed away. Mother
Mm-hmm.
has died when she was small, and she doesn't know the reason. Father has died due to a stroke,
Okay.
and one of the sibling has died during childhood, where she doesn't know the illness.
Right.
Her husband is a laborer, and
Mm-hmm.
currently she is living with her daughter. And
Mm-hmm.
daughter is having 2 children with ages of 2.5 years and 3 months. And
Okay.
she is unable to accompany her with clinic visits, and the daughter's family is also financially unstable.
Okay.
The closest hospital for them is NHSL, which is 30 minutes away from their home, and it
Mm-hmm.
takes around 600 rupees for a three-wheeler to
Mm-hmm.
reach the hospital.
Okay.
She has been educated up to grade 8, and she has a poor knowledge regarding the illness and the treatments and the side effects of the uh, and the complications of the illness.
Okay.
Her son is a clergy, and
Mm-hmm.
she is getting financial support from him.
Okay. Right. Fine. Uh, right. Could you just run through the examination as well, Dhananjay?
On examination, she
Mm-hmm.
is cachectic and
Mm-hmm.
pale. She
Mm-hmm.
has poor oral hygiene, and there are no lymphadenopathy and clubbing as well.
Okay.
She doesn't have ankle edema.
Mm-hmm.
On cardiovascular examination, she
Mm-hmm.
has a regular pulse with a rate of 72 beats per minute, and
Okay.
the pulse was low in volume.
Okay.
All the peripheral pulses were present.
Okay.
Blood pressure was 110 by 90, and
Mm-hmm.
there were no visible apex, and
Mm-hmm.
the apex was deviated, and it was in the sixth intercostal space, 2
Mm-hmm.
centimeters away from the midclavicular line.
Okay.
Second heart sound was palpable, and
Mm-hmm.
there was no parasternal heave.
Okay.
On auscultation, there was a ejection systolic murmur at the aortic
Mm-hmm.
area, which radiates to the carotids.
Mm-hmm.
Her respiratory rate was 28 per minute, and there was vesicular breathing. However, there were no crepitation when I was examining her.
Okay.
On abdominal examination, there was no tender points, and there was no organomegaly.
Mm-hmm.
Free fluids and bowel sounds were present.
Okay.
On nervous system examination, she has reduced visual acuity in the right side of her eye.
Mm-hmm.
Otherwise, the cranial nerve examination findings were normal.
Okay.
On upper limb examination, on inspection, there was a thin eminence wasting in bilateral hands.
Mm-hmm.
However, there are no surgical scars or tremors.
Okay.
Bilateral upper limb tone was normal. Power was
Mm-hmm.
5 out of 5,
Mm-hmm.
and reflexes were normal.
Okay.
There was a sensory loss over the lateral two fingers in bilateral upper limbs.
Hmm. Mm-hmm.
Coordination was normal.
Okay.
On lower limb examination, uh, on inspection, there was a loss of arches of the lower limbs, and there was
Uh-huh.
hallux valgus, and
Uh-huh.
there were no callosities, and however, there was prominent dorsal guttering and
Mm-hmm.
wasting of quadriceps.
Okay.
Uh, Bilateral lower limb tone was normal.
Mm-hmm.
Power was difficult to assess as she was complaining of pain, and
Okay.
reflexes were normal.
Mm-hmm.
And there was a flexor plantar reflexes as well.
Mm-hmm.
The coordination was normal, and
Okay.
there was a sensory loss of stocking type sensory
Mm-hmm.
loss up to
Mm-hmm.
the level of knee.
Okay. Okay. Fine.
So,
Okay. Right. So that is the case. Now, I have to, before we start the discussion about this patient, I have to tell you that this case is probably a little bit too complicated for an undergraduate exam. Okay. Because remember, these sessions are focusing on the exam, remember? So I think this is more of a MD part 2 sort of patient because there are many problems in this patient. But that's okay. We will sort of convert it into an undergraduate discussion, which is fine. Okay. But this is actually speaking, this is more of a postgraduate case because as you can see, and if you listen to the history, and the examination, there are many problems in this patient. Okay, and probably more towards a postgraduate sort of viewpoint. But that's fine. I'm going to select out and sort of adapt it to an undergraduate discussion. Now, before we move on with that, if you get this sort of complicated history for your exam, you have to be careful because you're definitely going to run out of time. Now, Dhananja presented a very detailed history, which is excellent, but now you also need to think of timing at the exam, okay? Because you don't have 2 hours to take a history, okay? You only have about 20 minutes to take a history, okay? 20-30 minutes because you have to examine the patient also. So you have to be careful and very mindful of time in this long history. And also when you present, some of the details you don't have time to present, okay? Now, obviously, we will help you to sort of cut down the presentation and sort of move you along if you take too much time. But sometimes be careful. Now, this presentation would easily take the full 20 minutes if you are not careful. So remember that you need to cut down certain information and sort of give a concise summary of certain points, right? Now, for example, in this case, diabetes history, Dhananjay, you explained it in absolute detail, which I don't think is necessary. You can just say, for example, microvascular complications, the patient has retinopathy, neuropathy, whatever. You don't have to describe all of that as well. So don't waste a lot of time in describing those sort of details. But remember, you're presenting this at the exam and you need to be mindful of time. But otherwise, of course, this is an excellent detailed history and examination. But what I'm thinking of is if you're going for the exam, you need to be a bit careful to and summarize points. Okay, so that is what is important. Okay, now if you were to present this case at an exam, let's break down the sort of questions that would be asked. And remember, this sort of case is common at exams because there are plenty of these patients where you can get. This is slightly too complicated, but a patient with a few problems like this can appear. For example, heart failure, diabetes only in a patient you can get as an undergraduate. Okay, but this is slightly more complex. Lots of things going on. Right. Now, the first question is obviously if I were to ask you, so they will ask you to summarize it. Okay, they will ask you to summarize and give a problem list. Give a problem list. Dhananja, would you like to tell us your problem list? So past few days I have been asking you summaries, but have you written a problem list for this patient?
Yes, sir.
Okay, so what are your problems?
She's a diagnosed patient with diabetes mellitus, hypertension, and dyslipidemia for more than 10 years with poor compliance for drugs.
Okay.
And there's features of diabetic neuropathy. And she has experienced ischemic heart disease events 4 times during the past period.
Okay.
And she's having a bronchial asthma and currently on controlled inhalers. And she has features of osteoarthritis where she is not on proper treatment.
Yeah, can I just stop you there? So when you are presenting a problem, remember you're learning, everybody is learning, so it's not a problem. So when you're presenting a problem list, you can say that you can give us very short opening statement. You can say this 59-year-old female with multi-morbidity. Now that's a nice word to use, okay? And especially if you present this sort of thing to Saroj, he'll be absolutely elated about. So basically, without sort of going in detail about all the list of medical problems a patient has, you can say this 59-year-old with multi-morbidity. Multi-morbidity means there are many medical issues in this patient. In this patient, 59-year-old patient with multi-morbidity, there are active problems and non-active or chronic problems. So that is how you start presenting a problem list. Okay. So active problems and non-active. Another word for non-active problems is chronic problems. So what is the active problem, Dhananja? What is the active problem in this patient? The active problem by definition is the one that brought the patient into hospital. And this can be medical in most cases, obviously, but might be also non-medical. So what is the medical, so active problems could be medical, non-medical. So what is the active medical problem that brought this patient into hospital then?
Worsening of shortness of breath, probably due to a heart failure.
Very good. So you don't have to describe it too much. The active medical problem is worsening shortness of breath. That's it. Okay, don't talk any further. The examiner will ask you about your differential diagnosis. So the first sort of active medical problem is this patient has worsening shortness of breath. So 59-year-old patient with multimorbidity. The first active problem that you have discovered is the patient has worsening shortness of breath. So that is your first problem. Okay, that is your first problem. Right. Then what else? What are the other active problems the patient has?
Poorly controlled diabetes mellitus.
Very good. So second active problem, patient has poorly controlled diabetes mellitus, and you can go on to say with macrovascular and extensive microvascular complications. That's a nice way of putting it, right? So poorly controlled diabetes mellitus with microvascular and macrovascular. These are extensive complications. Very good. Any other active problems that you would like to tell me about?
Poorly controlled hypertension and dyslipidemia.
Okay. So poorly controlled hypertension and dyslipidemia. Very good. What else?
Bronchial asthma.
Yeah, that's not a concern at the moment, is it? It is in the chronic problems, but the active problems. I would also say another major active problem is this patient's poor compliance and refusal, or at least not coming for follow-up. That is a non-medical problem, but it is still an active problem. This patient, as Dhananj, if you listen to her carefully, she said that this patient is not going to clinics, going for Ayurvedic medication, going to the pharmacy and taking medication of old prescription. So she's not coming for follow-up, and she's probably not taking her medication. She's been referred for CABG. She has been asked to take insulin. She's not doing none of that. So poor compliance and probably poor knowledge about the disease would also be an active problem. So you need to generate a list in the discussion. So if I was to examining Dhananjaya on this patient, of course, I would be mindful that this is a slightly complicated patient for an undergraduate, and I would give you a little bit of freedom and room for error. But I would say that this is a 59-year-old with, I would ask you, right, what are the problems? So I would say, Dhananjaya, if I were you, I would say 59-year-old patient with multimorbidity comes the range of active and non-active problems, which are medical and non-medical. If I would start with the active medical problems, the first thing I have identified is a patient has presented progressive shortness of breath. Patient has poorly controlled diabetes mellitus with extensive macrovascular and microvascular complications. Third problem would be the patient also has other metabolic comorbidities like diabetes and hypertension and dyslipidemia, which are poorly controlled as well. I have also identified as a significant active problem that the patient has very poor compliance, interest in management, and does not know adequately about her conditions. So that would be your active problem. In the non-active problem, you can mention all of the others like bronchial asthma, old history of TB, all of that you can mention, right? So that osteoarthritis, all these things you can mention in the background or non-active problems. So you need to discuss that very nicely. Okay. Now, if that is clear, now I start asking questions. Right. First thing, what is the differential diagnosis of this patient's shortness of breath? What do you think is causing the shortness of breath? You need to answer. So what is causing the shortness of breath? And you will understand the questions I am asking are very generic questions. But remember, the questions that I am asking are very generic questions, and long case so that's the importance of all of you listening very carefully to these sessions in the next 8 weeks, right? Because I won't have time again to do this before your exam, right? And make sure that your exam is not far away. Right? Okay, so obviously the first thing you would say is this patient, and I think all of you agree that the shortness of breath is probably due to heart failure. the shortness of breath is probably due to heart failure. Then එහෙම කියලා මදි. You need to back it up. නැත්නම් examine ගත්ත කට්ටම හරි හරි. You have to make a, why do you say it's heart failure කියලා අහන්න කලින් you say I think the shortness of breath is due to heart failure because කියලා you need to qualify or you need to prove it and give evidence for it, right? So what do you, so you say that this patient has significant risk factors for heart failure. Significant risk factors for heart failure. And I think Dhananjay has emphasized on several points that this patient has significant ischemic heart disease, right? Significant ischemic, right? Up to the point of she requiring a cabbage or a bypass graft. So that means she has significant ischemic heart disease. That is a very strong risk factor for heart failure. Number two, the patient has hypertension, which is again a very strong risk factor for heart failure. So the patient is, and diabetes, poorly controlled diabetes would obviously precipitate all of these problems. So patient is at a very high risk for heart failure. So therefore, that is a very good evidence-based fact that the patient probably has heart failure and that is causing her shortness of breath. The second point is why you say this is heart failure is that the patient has progressive shortness of breath, which is exertional in nature, and two of the very characteristic symptoms of heart failure, especially left ventricular failure and pulmonary edema. Okay, so what are these? Number one, orthopnea and paroxysmal nocturnal dyspnea. So these are the two key symptoms that you would get in heart failure. Okay, so patient has a good risk factor predisposition. Patient symptoms are very suggestive or supportive of heart failure, where the patient has progressive shortness of breath, orthopnea and paroxysmal nocturnal dyspnea. Patient, however, does not have edema, but I'll come to that in a little while. Okay, so because of these points, I would say the patient has heart failure. Okay, and that is causing her shortness of breath. Then othentoma, you can also also add the fact that the patient on examination has certain signs which are suggestive of heart failure. History on the examination, you need to have ලස්සනට කියන්න. So in the history, I thought she had a very significant predisposition. She had all these risk factors for heart failure. Her symptoms are very suggestive of heart failure, where she has exertional dyspnea, orthopnea, paroxysmal nocturnal dyspnea, no edema, but that's not a major problem, doesn't go against the diagnosis significantly, right? Then on examination, I also found that the patient had other features of heart failure, like a displaced apex, which is one of the key features. Did the patient have elevated jugular venous pressure, Dhananjay? I didn't catch that when you were presenting, sorry.
No, sir.
No elevated
I couldn't.
You couldn't. So you need to examine for elevated JVP, because that also is something you see in heart failure, especially when the right heart is failing. The next thing you need to, were there bibasal fine crackles?
No, sir.
Okay. So also look for those. Those are all other features of heart failure on examination. Bibasal fine crackles, pleural effusions, right? In more severe advanced case of heart failure, you might get pleural effusions, right? And pulmonary edema, so all these things. But the fact that the cardiac apex is displaced is good evidence that this is probably heart failure. So ඔය ටික ඔක්කොම ලස්සනට කියාගෙන යන්න ඕනේ. Okay, ඔය ටික ඔක්කොම ලස්සනට කියාගෙන යන්න. Right? So that is causing a shortness of breath, most likely heart failure. Now, if somebody asks you, right, what is the etiology of heart failure? Yes, you have already done that. You have already talked about that. Another key point I would bring up at this stage is, I am rather concerned that I found features of what is the murmur that you heard? What is the diagnosis of that murmur?
Aortic stenosis, sir.
Yeah. So, ඒකත් උතෙන්ට ගහන්න, because that is very important, and as you will realize, very important in the management as well. So, then you say, fine, I also found the patient had aortic stenosis in my examination, which is probably contributing to the heart failure as well. Okay, so that is a sort of supplementary evidence that which is probably contributing to the heart failure, aortic stenosis. Okay, so that is very, very important to mention as well. So that is your most likely diagnosis of heart failure. Now remember, differential diagnosis, chronic kidney disease is another possibility, right, which can present in the identical way. But remember, the patient doesn't have a lot of peripheral edema, right? Peripheral edema, which you would expect in patients with chronic kidney disease. Now, this patient has a lot of risk factors for chronic kidney disease. Poorly controlled diabetes, hypertension, all of that would be risk factors for chronic kidney disease. And chronic kidney disease can also present with fluid overload, shortness of breath, orthopnea, and paroxysmal nocturnal dyspnea. But the fact the patient is not swollen goes slightly against that diagram. That's why we put it at number 2. Because the patient has doesn't have a lot of edema, which in renal disease you would expect to have. Right. So heart failure persisting with a probable contribution from the aortic stenosis, right? Second differential diagnosis we are talking about, could this be CKD? But because there is no edema, it is less likely. We will discuss. Now, ඔතනින් නවත්තලා කවුරු හරි આવුත් මේක දැන් asthma වෙන්න බැරිද? Couldn't this be bronchial asthma? Patient has asthma and just on a inhaler for reliever inhaler එකක් විතරයි නේද? So could this be asthma? So then you say confidently, no, it is unlikely to be asthma. Okay? No, it is unlikely to be asthma. And ඒවට තමයි ලකුණු හම්බ වෙන්නේ. මේක නම් obviously asthma නෙවෙයි. But ඔය දැන් බය නැතුව නෙවෙයි කියන සමහරලාට අපි හිතන් ඉන්නවා එක්සැමින මොන හරි ඇහුවොත් එහෙම මේක මේ අපිට වැරදිලා මේක ඇත්තටම ඇස්මා වෙන්න ඇති එහෙම කියලා හිතනවා. නමුත් එහෙම කියලා මේක ඇස්මා කියලා පිළිගන්න ළමයා fail. හරි ඇස්මා නෙවෙයි කියලා. If you say no, this is very unlikely to be asthma, then you will get a very high mark, right? Because now the examiners are හිතන එකෙක්. මූට නිකන් කිව්වට ඒව දේවල් පිළිගන්නේ නැහැ කියන එක, that is important, right? And in many exams this happens. This happened to me in not in my undergraduate exam, postgraduate exam එකේ neuro case එකේ මොකක් හරි මට හම්බුණා. මම කිව්වා මේකයි කියලා. ඊට පස්සේ මේක වෙන්න බැරිද කියලා. something මොකක් දෙකක් වෙන්න බැරිද කියලා. මම කිව්වා ඒක වෙන්නම බෑ. මේ හේතු නිසා මේක වෙන්නම බෑ කියලා. So I had apparently got very high marks for that neuro case because මට කලින් ආපු ඔක්කොම අර වැරදි එක කියලා තියෙනවා. ඉතින් මගෙන් ඒවා මේක වෙන්න බැරිද? මම කිව්වා ඒක වෙන්නම බෑ. මේ හේතු හින්දා මේක වෙන්න බෑ කියලා. ඒ වගේ. So ඒ වගේ කියනකොට ලකුණු වැඩිපුර දෙනවා. So right. So this can't be asthma because of several reasons. The first reason being that asthma is classically a intermittent disease, right? So you never get progressive shortness of breath in asthma, right? Asthma, as we have discussed before you started professorials, when we are talking about shortness of breath, it is an intermittent disease. So it doesn't cause progressive shortness of breath. And almost always there would also be some triggering event for asthma. නේද? some triggering event එකක් තියෙන්න පුළුවන්. Okay, right. So the intermittent nature, there is no triggering. So this is not intermittent. There is no triggering event. නේද? So it is very unlikely to be asthma, and you didn't find any wheezes or anything on examination. So ඒක වෙන්නම බෑ කියලා කියන්න ඕනේ. වෙන්නම බෑ කියලා කියන්න. Now, other possibilities that you might need to think of but are less likely in this patient are probably something related to tuberculosis, right? So, is this new shortness of breath a recurrence of TB or is it consequence of TB? එක පොඩ්ඩක් ඔළුවේ පැත්තක තියාගන්න ඕනේ. But remember, the patient against that diagnosis would be the patient does not have any night sweats or fever or anything like that. Okay? So ඒක පොඩ්ඩක් පැත්තේ කවුරු ඇහුවොත් මේ TB තිබිලා තියෙනවා මේක TB වෙන්න බැරිද කියලා වගේ ඇහුවොත් ඒක again you say it's possible but less likely because the patient doesn't have any loss of appetite, loss of weight, night sweats or fever or anything like that, right? And remember I told you that TB would usually almost always cause loss of appetite, loss of weight and night sweats with fever. So මේක TB වෙන්න අමාරුයි and there is no cough or anything. So it unlikely to be related to TB, right? Hari. So that's how you discuss and bring up the point. You were talking about smoking, and Dhananja very nicely mentioned that it's less likely to be COPD in the history because she's not exposed to it, and there are no evidence of exacerbation, which are the cardinal feature of COPD. Okay, Hari. So knowingly or unknowingly, I've gone through with you all the common causes of shortness of breath, right? And we have done this before, so please revise that. Then තේරෙනවද උත්තර දෙන විදිහ? Now the past 2 sessions, now this is the third session we are doing, you will understand the way that you answer. Then may sessions ඔයගොල්ලන්ට කරන්න, and this is not something that you will always get in your classes in the morning, because there the emphasis slightly different and you need to listen to those classes, of course. But remember that you're finally going for exam, sitting for exam that is going to decide the rest of your career. So you need to know the tips and tricks on how to get a good mark. So this is the way you answer. උත්තර දෙන විදියම ඔබලට උගන්වනවා. So please make sure that you get this into your heads, right? So what is the question we are answering? We are saying, right, this patient's first problem is progressive shortness of breath. And what is the differential diagnosis? I think you think it's most likely due to heart failure because the patient has risk factors, predisposition, the symptoms are very classical, exertional dyspnea, orthopnea, PND, edema නැති එක වැඩි ලොකු කරබලයක් වෙන්න දෙයක් නැහැ. Examination, I found that the apex was displaced. I was looking for elevated JVP and basal crackles, but I couldn't elicit them. But that is පොඩ්ඩක් පැත්තෙන් දානවා. The fact that the patient has aortic stenosis is also troubling, and this might be promoting this heart failure කියන එක you need to point out to the examiner. If they ask you තව මොනවද වෙන්න පුළුවන් කියලා, then chronic kidney disease, but because there is no edema, it is less likely. Cannot be asthma, very unlikely that is related to TB, recurrence or something like that, and COPD is less likely. So it can mainly අපි heart failure පැත්තට තමයි ඕක ඇදගෙන යන්නේ. heart failure පැත්තට තමයි ඕක ඇදගෙන යන්නේ. හරි. Right. Now, how long are the symptoms, Ananda, this time? How long are the symptoms?
1 week, sir.
1 week. The next question that the examiners ask you, right, hey then, this patient has had ischemic heart disease for 8 years, several episodes of ischemic heart disease, what is, so in other words, what is decompensating the heart? What is decompensating the heart? So 1 week symptoms. Why is that decompensation now? So what are the possibilities? Number one, the patient could be having an acute coronary syndrome, right? Now remember, acute coronary syndrome can එකපාරටම මේ present වෙන්න ඕනේ නැහැ. Can be a sort of a gradual build up, or it's also called a crescendo ACS. ඒ කියන්නේ පොඩ එනවා. Right? Those of you who have done music know what crescendo means. It gets එකපාරට පොඩ වැඩි වෙනවා. But there is no chest pain, but you're not surprised, because why are you not surprised? The patient has significant neuropathy, and therefore silent ischemia is very possible. So I'm answering the question, what is causing the sudden presentation, right? Decompensation. So possibility number one, could this be an acute coronary syndrome, which is sort of silently building up? Is it this silent ischemia that is building up, and this patient is presenting with shortness of breath, very rapidly progressing over the last week? So is that possible? The second thing is maybe this aortic stenosis, right? It is now critical aortic stenosis and it's getting worse, and that is what is causing the sudden decompensation. So two explanations. Dhananja, this patient has osteoarthritis. Is she taking any treatment for it at the moment from the pharmacy?
She's taking medicine from the pharmacy, but sir, these usually she's taking drugs for shortness of breath mainly, because she don't have money. She has a list of drugs to take.
Okay.
She's selecting the drugs that are given for shortness of breath and taking them.
Right. Has she taken any painkillers in the last few weeks?
I didn't specifically ask that.
Now, what am I trying to get at? There are certain drugs that cause decompensation of heart failure. And one of the very common ones are NSAIDs. Very common ones are NSAIDs. The other ones are any drugs that cause fluid. So NSAIDs cause fluid retention. Other drugs that cause fluid retention are steroids, which sometimes people take over the counter for aches and pains. So NSAIDs, steroids, also anti-diabetic drugs like pioglitazone. Okay, the things like thiazolidinedione family, they also cause fluid retention and worsening of heart failure. Okay? So that's what I was trying to get at. So you're building up a hypothesis in your mind, right? Is this lady suddenly starting to take medication for knee pain like NSAIDs or steroids, which cause fluid retention, or something, or have the diabetes drugs changed, and is she now taking a thiazolidine, which is sort of building up the fluid? If you think of that sort of thing, I'm definitely going to give you a distinction where the ගොඩක් medicals වල ඒක ගැන හිතන්නේ නැහැ. But that is another possibility, and those are the three common causes of worsening. And sorry, I forgot the fourth. The fourth one is dietary changes. So sometimes people take more salt and more water, fluids and over වෙන්න පුළුවන්, or they come off their diuretics. So those are the 5 common causes of decompensation in heart failure patients. So silent ischemia would be a possibility in this patient because it's extensive autonomic neuropathy probably, and all these to the heart, and she won't feel any pain. So is that what's building up now? Is the aortic stenosis rapidly getting worse and it's now presenting critical aortic stenosis, very severe aortic stenosis? Is that presenting now with heart failure? Is she taking any over-the-counter medications for her pain? And we very, very well know that NSAIDs and steroids, all of these can cause fluid retention and then cause worsening of heart failure. Or has there been a change in the diet? Is she taking more salt and more fluids? Is that possible? We have already known that this patient has a very poor compliance to medication. So is she not taking, has she been prescribed diuretics in the past and she's not taking them now? And is that the reason for her heart failure to be decompensating? Okay. So at an undergraduate level, ඔය කාරණා පහ කියන එක හොඳයි. ඕකෙන් තුනක්වත් ඉතින් කියන්න ඕනේ පාස් වෙන්න. Okay. So that's when we move on to the next question. Okay. Fine. So 2 questions we have asked at the moment. Number 1, we have talked about her shortness of breath, most likely cause. Then if it's heart failure, what is triggering or precipitating this sudden decline or worsening? Okay, because she's had shortness of breath for quite a long time, according to Dhananjay. But what is causing is 1 week deterioration. I'm sorry, I forgot one more. A list list. The next one is infection. So infection, so for example, pneumonia can cause but may patient take a කියන්න යන්න එපා මොකද මෙයාට උණ මුකුත් නැහැනේ. But a common cause for heart failure worsening is actually chest infections like pneumonia. Okay, but not in this patient because she doesn't have any other features of infection. All right. Okay, so those are the 2 key things that you would talk about. Hi. Third question in this long case. Fine. The patient comes to your ward now. How would you confirm the diagnosis of heart failure now? Okay, how would you confirm the diagnosis of heart failure? And I've taught this to you, right? So let's just list out the things now. Obviously, when the patient comes in, you'd request for basic cardiac investigations. ECG and chest X-ray would be at the top of your list, right? Now, ECG would obviously be important because it will show features of ischemia, and then you can do troponin to see if it's significantly high. Okay, right? Do they do high sensitivity troponin now in NHSL? Does anybody know?
Yes, sir, they do.
So they do the high sensitivity now.
Yes, sir.
Yeah. So high sensitivity troponin, you can send that off. It's very, very sensitive for ischemia. Okay. So and the ECG might show ischemia, and that make a silent ischemia you pointed out, and that is something which we can do, right? Heart failure per se on the ECG, you would find poor R wave progression, in the precordial leads, right? Moving on, X-ray, all the X-ray features we have discussed before, right? Hilar prominence, upper lobe diversion, curly B lines, pleural effusions, cardiomegaly. Abhi MCQ karanakota, cardiovascular MCQ karanakota, I have covered this, right? So please remember, write it down. Hilar prominence, upper lobe diversion, curly B lines, and pleural effusions, right? And then obviously you would request for an echocardiogram, which is going to give you a diagnosis of either heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. Okay? Right. The additional advantage of doing echo in this patient is basically to obviously assess the aortic stenosis as well. So, ඒක අමතක කරන්න එපා. ඒක ලොකු point එකක් මෙතන ළමයි. Aortic stenosis එක ලොකු point එක. ඒක detect කරපු එකට ලකුණු හම්බෙනවා. and ඒක හැමතැනම පොඩ්ඩක් වවාගෙන කන්න ඒක, because that is a good point to proceed with. So aortic stenosis, you would assess that in the echo. Hari. Okay. Then you'd obviously send a panel of basic investigations, blood tests, full blood count, creatinine, electrolyte, ඒ වගේ දේවල්. Do they do BNP in NHSL?
It was not available with the patients. It is
NHSL
stated.
ගේ BNP කරනවද දැන් මන් දන්නේ නැහැ. I don't know. I've been there for a year now. Just find out if they're doing it, because that is again a very good marker of heart failure if it's elevated. Okay, BNP or NT pro BNP, both tests are available in the private sector, I know, but I'm not sure whether they do it in NHSL. Okay, so BNP ඒවා කරන්න පුළුවන්. BNP is elevated in patients with heart failure. So you can do this, and that's how you would diagnose or confirm the diagnosis of heart failure. Right. So 1, 2, 3 questions. First of all, differential diagnosis. What is causing the sudden worsening? Third, how would you confirm the diagnosis? Fourth question, okay, is right. Now, how would you treat this patient? How would you treat this patient? Assume that there is no active ischemia going on. This is just a progression of a heart failure. Okay. So assume there is no active ischemia. Now, how will you treat? So remember that treatment, you need to make sure the patient is symptomatically treated, okay, and that is with diuretics, okay, furosemide, sorry, and then the patient should be on the, you need to check whether the patient is on the first line medication for heart failure, okay, and these first line medications have a mortality benefit, So what are these medications? All of you know this. I'm just revising, running through this, and at the exam you need to say the patient should be on an ACE inhibitor. The patient should be on an ACE inhibitor. Dhananjay, is the patient on an ACE inhibitor? Do you know?
Yes, sir.
Okay.
She's
And
on an
has the patient had echoes, ECGs, and X-rays? Can you tell us the findings if you have them?
So this is a casualty patient, so
Right.
I
So
cannot write them.
okay, so make sure that you go back and try to see if you can find out echo and anammanam ඒව ටික ejection fraction ඒව ටික අපිට දැනගන්න පුළුවන්. හරි? Okay, that's fine. So that's fine. So then so the patient should be on a diuretic, which is for symptomatic benefit, and the first line drugs are ACE inhibitors, and the patient should be on a beta blocker. Is the patient on a beta blocker?
Yes, sir.
Okay. What beta blocker? Carvedilol වෙන්නේ නැති ගොඩක් වෙලාවට. මොකද ඒක තමයි commonly පාවිච්චි කරන්නේ. So carvedilol, bisoprolol or metoprolol would be options there. Right. And generally at this stage, the patient should also be on spironolactone. It's actually a second line drug, but it is useful. So spironolactone is useful for patients with heart failure with reduced ejection fraction and an ejection fraction of less than 35%. Okay, ejection fraction of less than 35%, and obviously heart failure, symptomatic heart failure. So spironolactone, but that is added on to the other ACE inhibitor, beta blocker, spironolactone. So is the patient on spironolactone?
Yes, sir.
Okay, right. So ඔගොල්ලෝ ඔය තරමට දැනගත්තා නම් ඇති. Okay, ඔය තරමට දැනගත්තා නම් ඇති, and they will ask you some common side effects of these medications if they go on the pharmacology thing. So please refer some of the common side effects of these medications. So tell the examiner that I would check with the patient is on furosemide, a good dose of furosemide, and I would also check if the patient is on a ACE inhibitor, beta blocker, and possibly spironolactone as well. Remember, the indication for spironolactone is at a second line. Once you start the ACE inhibitor, beta blocker, continuing symptoms, ejection fraction less than 35%, you add the spironolactone in. Okay, so these three are the commonest used drugs for heart failure. Now you know that in the moving on, there are other drugs for heart failure, right? Like digoxin, hydralazine, and nitrate combination. Okay, digoxin, hydralazine, and nitrate combination. And this new ANI or whatever it is not available in Sri Lanka yet. Okay, ඒවා අපි පාවිච්චි කරන්නේ නැහැ. Okay, so other drugs are hydralazine nitrate, which is basically a vasodilator, and also the digoxin. Digoxin doesn't have a mortality benefit, but it actually prevents hospital admissions. Okay, so ඒ ටික මේවා කරන්න පුළුවන්. So ඔය ටික බලලා then ඊට පස්සේ කියන්න ඕනේ ළමයි මේ patient then very she's quite young නේ, she's 59 and that's quite young. Okay. මේ based on UK standard this is basically equivalent to about 20 years. මොකද මෙහි එන ඔක්කොමලා එන්නේ අවුරුදු 90 95 විතරයි තමයි ස්පිතාලෙට admit වෙන්නේ. So if you get a 59-year-old, that is considered to be a very young patient. So quite a young patient, and obviously you have to look into other options as well now. දැන් අපි medical management එක දැන් අපි පොඩ්ඩක් අයින් කරලා ඉතුරු ටිකත් කතා කරමු. because already ඒක කිව්වොත් එහෙම you will get more marks now. Okay. So what are you going to say? You will refer this patient to cardiology, right? First thing you will do, refer this patient to cardiology. And now two things. Patient has aortic stenosis, so and if there is aortic stenosis and heart failure, the patient will definitely need some intervention. Okay, so you will refer the patient to cardiology to assess for suitability for intervention. As you know, severe aortic stenosis, there are features. If they are symptomatic. Symptomatic කියන්නේ angina or syncope or heart failure. Okay, if they have any of those three, they are at a very high risk of dying in the next 6 months. So they need to have an intervention. So first thing you will do is you will refer to them. The other thing is see if there's a possibility of revascularizing this patient, and that might improve the heart failure. The second thing you are going to ask cardiologists, could you, if revascularization එකක් කරොත් ප්‍රයෝජනයක් තියෙයිද? Revascularization එකක් කරොත් ප්‍රයෝජනයක් තියෙයිද? And they do certain additional investigations to check that, okay, which are bit beyond undergraduate level. Stress echoes and nuclear cardiology that they assess whether reperfusion, if we re-establish blood flow into the heart, will that improve the heart function? Okay, there are investigations like stress echoes and nuclear scans. But I have discussed some of them in your MCQs, right? So you are going to refer. So so you say how you manage this patient, you are going to do the sort of medical management, and then you're going to refer cardiology with two questions in your mind. One, does this patient need aortic valve replacement, right? Second, for example, if you do a coronary artery bypass graft, will that improve the patient's heart failure symptoms and signs? So ඒක වෙන්න නම් heart එක මැරිලා නැතුව නිකන් නිදි තත්වයක, they will call this a hibernating state එක තියෙන. ඒතර blood flow එක ආයි දීපු ගමන් පටස් ගාලා මේක වැඩ කරන්න පටන් ගන්නවා. හරි? So then the symptoms go away. So two questions from cardiology from this patient. Okay, so refer to cardiology, ask them two questions. Aortic valve and second, bypass. Right. Okay, so these are the things that you would do. Right. ඕක කියලා නවත්තන්න කලින් how would you manage this patient කියන එක කියන්න ඕන වැදගත්ම කාරණයක් තමයි ළමයි. You have understood that the patient has very poor compliance to medication. So you address that fact as well. නැත්තම් මේ කරන කිසිම කාරණයක වැඩක් නැහැ. You will sit down with the patient, educate them about the importance of this, and then make sure that the patient attends clinic, has a proper follow-up arranged, and is compliant. So ඒක අමතක කරොත් මේ ඔක්කොම බින්ද වැටෙනවා. You can understand whatever you do, ඔක්කොම medical manage කරලා cardiology refer කරලා වැඩක් නැහැ. ලෙඩාට කිව්වේ නැත්තම් මේකේ බරපතලකම. So you need to tell the patient this is the problem and you will die if you don't go. එච්චර බය කරලා කියන්න එපා. Obviously you don't say that to the patient, but impress the importance of this follow-up, going to cardiology, taking her medication regularly and properly, right? That is very, very important. So that's the complete answer for the question, what would you do to manage this patient? Hari, what would you do to manage this patient? I'm only talking about the heart failure. Just remember. Hari? Okay. Hari. So that is about heart failure, right? So, and this patient. Now, remember that මේ patient ගේ තව අහන්න පුළුවන් diabetes ගැන අහන්නත් පුළුවන්. But I'm not going to discuss about diabetes. I'm going to do a separate longer discussion on diabetes. Okay? මේ patient ගෙන් දැන් උතනින් නවත්තලා diabetes treatment ගැන ඒව ගැන චුට්ටක් අහන්න පුළුවන්. Okay? Hypertension treatment ගැන අහන්න පුළුවන්. There are so many things that examiner can ask from මොකද ලෙඩ ගොඩක් තියෙනනේ මනුස්සයට. හරි? අනේ මට කියන්න අමතුන heart failure management optimize කරනකොට you need to optimize the ischemic heart disease management කියන එක ඒකට ලියා ගන්න. So point of doing the cardiology referral might also be due to optimize the ischemic heart disease management, because that is also going to improve the symptoms to a certain degree. Okay, it will also improve the symptoms to a certain degree. Right. So that is what I would discuss from this patient. There are other things that you can ask, but I am not going to do them today. So you can talk about diabetes, you can talk about lots of other things from this patient's history, right? But I'm just going to, main focus is I want to talk about a long case of heart failure. What are the common questions that you get asked? And this is a very beautiful case to discuss that sort of thing. Okay. Hi. Now you can ask any questions on the chat, but I will just now summarize the class that we did today. Okay. Because I need you to focus on this and retain this, because this is very, very important for your exam. Okay. Hi. So today we discussed a 59-year-old with multi-morbidity. Okay, patient with shortness of breath for a week. Key learning points are, first thing, I taught you a little bit on how to write a problem list. I have not completed teaching that. I will teach you further as we go on. So I will teach you more as we go on. So how to write a problem list. So in this patient, problem list එක අපි පොඩ්ඩක් කතා කරා, active problems, non-active problems, and within that you can say medical or non-medical කියලා බෙදන්න පුළුවන්. And we identified about 4 or 5 medical problems in this patient, where the most prominent one being the shortness of breath. හරි. කළා අපි ප්‍රශ්න 5ක් 6ක් මේකෙන් ඇහුවා ඊට පස්සේ long case එකෙන්. First thing I asked you was shortness of breath. What do you think is the cause? And then went to do a nice discussion on heart failure and the symptoms. And ඒක ලස්සනට කියන විදිය කොහොමද කියලා. About, yes, this patient has a predisposition, classical history, examination is supportive. Then there is aortic stenosis, which is concerning, and that is probably causing, contributing to the shortness of breath. කියන එක අපි කතා කරා. Then we talked about differential diagnosis. CKD වෙන්න පුළුවන් ද ඉඩියම නැති නිසා එක අමාරුයි කිව්වා, but the patient has risk factors for CKD. Asthma වගේව වෙන්න අමාරුයි බෑ. TB වලට related වෙන එක is less likely because the patient does not have any systemic symptoms like fever or so on. හරි. ඒ ටික අපි කතා කරා. Then I asked the question, why is it suddenly worsening? And I gave you 6 possibilities that you might need to think of. හරි. එතකොට අපි කිව්වා මේක silent ischemia එකක් වෙන්න පුළුවන්ද? Is this aortic stenosis getting worse, right? Is this so is this any other cause like poor compliance, over taking salt and water too much? Could this be an infection? ඔය කතන්දර ටික අපි කතා කරා, possibilities, right? Then we went on, right? How do you confirm the diagnosis? ECG, X-ray, echocardiogram, BNP if you have access to it. And then also do the other baseline investigation, especially the renal functions are important as well. All right? Then about the management, medical education is very important. That ties up everything together. Medical management, make sure the patient is on the first line drugs for heart failure, diuretics, ACE inhibitors, beta blockers, spironolactone. Make sure the patient is on those medication, right? And then if you proceed, then you talk about, you will refer this patient to cardiology, especially asking 2 questions. One is, does the aortic valve need replacement because you've detected aortic stenosis? You think that that's causing or contributing to this worsening in this patient? So is there a place for aortic valve replacement? The second thing is, this patient has been referred for coronary artery bypass graft in the past. Do you think that doing that will actually improve her symptoms, for that the heart should not already be dead? Muscle එක දැනටවත් මැරිලා reperfuse කරා කියලා වැඩක් නැහැ. But if it's still hibernating or it's still sort of sleeping වගේ නම්, then you can, once you re-establish perfusion, it will start to work again, and that improves the ejection fraction as well. ඒක අපි කතා කරා. And also you will ask cardiology to look at her medication, make sure her ischemic heart disease treatment is optimized. And I'm not going to go into that at the moment. ඒව ටික කතා කරේ නැහැ දැනට. Ischemic heart disease and hypertension treatment. Sorry, එතන මේ දෙකම කියන්න පුළුවන්. Right? Because all of those contribute. ඒතර ඒවා manage කරගන්න එක ඉතා වැදගත් වෙනවා. Right. So that is about heart failure management, right? And how you adapt it to this particular patient. And then finally, we obviously said that this patient, you can ask other questions like diabetes management from this patient, but I am not going to go into that. Product aortic stenosis ගැනත් කතා කරා. So symptomatic severe aortic stenosis would be, symptoms would be chest pain, angina, syncope, and heart failure. If they have any of these manifestations, then the patient has a very high risk of mortality and requires intervention. Intervention is usually valve replacement, open heart surgery valve replacement, but now you have something called TAVI, that is a sort of cutaneous way of placing, invasive way of replacing an aortic valve. Hari, එතකොට ඔය ටික තමයි තියෙන්නේ. Any questions? Okay, right. So we have done 3 cases now here. We have done a case of PUO and hepatosplenomegaly. We have done liver, and now we have done heart failure.
Yes, sir.
Okay, so what do you want to do tomorrow?
CKD, sir.
Okay, right. That's fine. We'll do CKD tomorrow, which is obviously good to do because it's closely related to this case as well. So let's do CKD tomorrow. Find a case. Obviously, there are so many CKD patients there. Don't take a too complicated one, but try to find a good patient with obviously coming with fluid overload symptoms, and then obviously something like that. Yeah.
Okay, sir. Okay.
Hari, any questions, Lamai? Harida, is that okay? ඔගොල්ලෝ නිදිද මොනවද කියලා දන්නේ නැහැ. මේ පේන්නේවත් නැහැ නේද? Hope you are listening to this. Okay then? Right, fine. See you tomorrow.
Thank you, sir.
Okay, no problem. Yeah.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Okay,
Thank you, sir.
Bye.
Thank you, sir.